So again, good afternoon, and thank you for joining us for today's webinar on how to assess activity in juvenile systemic scleroderma. This session is going to be led by the fantastic Dr. Ivan Foeldvari. But before we get started and jump into the webinar, I want to go over a few just kind of housekeeping things to make sure everyone has an enjoyable experience. If you're logged in correctly, you should be able to hear my voice and see my image on the screen. If you're having any audio or visual difficulties, please try logging out of the Zoom meeting and logging back in. If the issues persist, feel free to direct message me in the Zoom chat, or you can email me directly at asoto@scleroderma.org, and I'd be happy to assist you getting back into the webinar. Today's webinar is being recorded and will be made available on our YouTube channel. I hope to have this video up by Monday of next week, so feel free to tune back in if there's something you'd want to review. Also, the National Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Information is provided to keep the listeners informed because the manifestations and severity of scleroderma vary among individuals. Personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. Again, this webinar is for educational purposes only. If you have any questions throughout the webinar, please feel free to use the chat or the Q&A function. I'll be monitoring that, and we will get to all of the questions at the end of the presentation. I'd like to introduce our speaker for today, Dr. Ivan Foeldvari. He's an accomplished medical professional with extensive experience and expertise in the field of pediatric rheumatology. He has significant academic training, hospital appointments, academic appointments, and various honors and memberships. He has been a member of the International Systemic Sclerosis Trials Consortium since 1999 and has contributed to the development of guidelines for juvenile systemic scleroderma and vasculitis in Germany. Furthermore, he's held leadership positions such as head of the Scleroderma Working Group of the European Pediatric Rheumatologic Society and head of the pediatric section of the German Scleroderma Network. As an investigator and international studies, Dr. Foeldvari has made significant contributions to the advancement of pediatric rheumatology and juvenile scleroderma. Thank you for joining us today, Dr. Ivan Foeldvari. The floor is yours.
Oh, thanks for the fantastic introduction. And I'm very happy to give this talk. And especially this meeting was supported from the Scleroderma Foundation and from the Scleroderma Clinical Trial Consortium. So I'm very happy to report to you what we achieved. The main topic of the meeting was how to assess activity in juvenile systemic scleroderma. Just to show you some pictures from Hamburg, perhaps you want to travel here. It's a very nice city. It's the second biggest city of Germany. Here you can see all the participants. This meeting is always a multidisciplinary meeting where we have pediatric rheumatologists, adult rheumatologists, other pediatric specialists, and we have patient representative. We have two representatives from FESCA, Linda Schemen, and another colleague, and it is very important that we have a patient input when we develop this kind of guidance. This is a picture of the group during the consensus meeting. And why is it important to assess activity in juvenile systemic scleroderma? Basically, the assessment of disease activity is guiding the treating physician to introduce the best treatment of patient to achieve the best long-term outcome, best quality of life, and very important in pediatrics, the normal psychosocial development for the pediatric patients. And therefore, we had this consensus meeting. It's a very important point. The European Medical Agency, who is licensing the drug in the EU, in the European Union, that agreed that juvenile systemic scleroderma is the same disease as adult systemic scleroderma. It means that basically the efficacy data, so if the drug is effective, can be extrapolated from the adults, but we still need data from patients, pediatric patients, if the effectiveness is similar in the children, but you don't need so many patients and there won't be any placebo-controlled trials. And we have to see what are the side effects, especially, I think, in adult studies, they never assess is there an influence on growth or psychosocial development or maturation, because these are not topics what adult physicians deal with. The prevalence of juvenile systemic scleroderma is much rarer than in adult scleroderma. It is around 3 in a million children. This is from a US insurance database, what we published recently. Most pediatric investigation plan, that mean if there is an adult study and the adult study at the beginning is quite effective, then the company has to submit a protocol for the European Medical Agency, and then they suggest to do, and they have to do a pediatric trial. But in the pediatric trial, mostly around 30 children will be included. But still, we have to look at the pharmacokinetics, special safety issues, but we don't look for efficacy because 30 children are not sufficient for that. But you want to have the same kind of direction that the drug is really working. The main aim of our meeting was to define pediatric activity measures, because you cannot extrapolate the adult measures because children are not small adults. We agreed to focus really on activity and not on response. And the consensus was defined in the meeting if 80% of the participants voted for the decision. The first consensus statement was that we wanted to include all patients who fulfill the adult 213 ACR classification criteria. The next slide, I will show you the criteria for you that you get an impression of that. And the patient should have the first non-Raynaud before the age of 16 years of age. A huge difference for adult studies that we want to ignore subsetting. You know that there are diffuse subset and limited subset, and there are patients who don't have any skin involvement. But basically, if the patient fulfilled adult criteria, then we don't care about the subset of the patients. As you see here, this is the adult criteria, and basically, if you have a diffuse skin involvement, what you see on the top here, then you already have 9 points. So, and yes, 9 points are sufficient to have a diagnosis of systemic scleroderma. But you can get the 9 points without the skin involvement, because you can have capillary changes, you can have Raynaud's, you can have specific antibodies, telangiectasia, fingertip lesions, and you will have systemic scleroderma in the child without skin involvement. First, we looked at global measures, and I wanted to show you like this VAS scale. Presumably, if you go to a clinic with your child and you fill out this kind of scales, and we agreed that the physician global assessment, when the physician says no activity, and here you have severe activity, basically, it's a very important measure. We agreed that the serum inflammatory markers can be a measure for disease activity. It is not really clear which one we will choose. We considered that patient-reported worsening of carcinosis is really a very good marker of disease activity, but is still the questionnaire has to be evaluated. Regarding skin involvement, I wanted to show this Menocam. Perhaps you all know this is the modified Rodnan skin score. And here you have this different anatomic regions where you score the skin. And here you on the right, you can see this is totally normal when you can make a real nice skin fold. And here basically you have a skin score of 3 when the skin is totally tight. Pediatric skin scoring is a little bit more difficult in adults because especially younger children before puberty have much more subcutaneous fat tissue. For that reason, we had a consensus meeting in Hamburg where we were looking what is the best way to define normal skin in a child. What we published with Cassie Torok from Pittsburgh in this best practice of research in 2021. And basically, we said that the texture and the feel are the same throughout the region of the body. The mobility of the skin is symmetric to the region, and you don't have any secondary features of scleroderma. So I think that's a pediatric definition, because scientifically, if you look at the skin score of a child of 3, I think because they have normal, much more subcutaneous fat tissue, you can't make real skin folds, and the child can be absolutely healthy. So we use the modified Rodnan skin score. What we agreed is an activity marker if it is moving, and it is considered if it moves with 5 points. So if you count the regions and you have the score from 0 to 3, the total score gets 5 points higher, or you have an increase of over 20% or 25%, or there are new areas which were 0 before, and you get a skin thickening. And absolutely, if the patient consider that there is a reported worsening, there are some adult studies which have already done this, and they showed that the patient reported worsening is totally correlating with the skin score what the physician is measuring. The next organ what we looked at is the lung disease. I just wanted to show you interstitial lung disease, which is a very important significant part of the disease, where you have a diffuse parenchymal lung disease, and it influences the breathing. It occurs around in 50% with juvenile patient, and here you can see on the X-ray where you have this kind of beginning fibrosis of the lung. It is the main cause of a severe disease, so it is very important to score it and to assess it on time. How it will be assessed, you do pulmonary function test. We see here this small boy is kind of breathing in this tube, and the most commonly assessed parameter is the functional vital capacity, which is the total amount of air exhaled during the forced breath. And you can assess the diffusion capacity of carbon monoxide, which is more difficult because you get a blown in the carbon monoxide and you have to breathe against it, and you need much more cooperation of the patient, and even the adults have problem with it. So it cannot be assessed in all pediatric patients, but it cannot be assessed all adult patients either. And then the gold standard is the high resolution computer tomography, which is basically what you see here, where is an imaging which have slices of the lung, and you can see if you can assess if there is a fibrosis. Just for the sensitivity, we published from our juvenile Scleroderma inception cohort, which is a cohort which now have currently around 280 patients worldwide with juvenile systemic scleroderma. If your child is not part of it, please ask your physician that they should be part of it, because each patient count for this kind of rare diseases. And here we could have shown that if you do just pulmonary function test, we had the gold standard of a positive finding on the high resolution CT. And we saw that some children, and that it's actually 60%, had normal pulmonary function test, even in a case where you had already beginning fibrosis. And it is actually not surprising in a way, because children have a functional vital capacity of 120. And I think most adult studies show that if you have under 80, you are concerned. But even if you would drop from 120 to 100, then you have a severe drop. And this is a severe progression of the disease. But with 100 functional vital capacity, the child has no complaints at all. So therefore, it's very important to really assess all children with high resolution CT. So what we agreed on, that functional vital capacity is a measure of disease activity as DLCO, and both of them, if you have a decrease in 10% or more, then it is a significant change. We agreed that high resolution CT is a measure of disease activity. And if you have a new lesion, I think progression in a higher CT, if you have over 10% increase in the higher CT in the surface, I think, which amount of the lung is involved, that is a clear increase. And there was not 100% agreement, but the 6-minute walk test is a non-invasive test, which is assessing the cardiopulmonary function of a child. And that is actually a quite interesting activity measure too. Next is the cardiac involvement. A cardiac involvement is the most common cause of mortality in children, even that is not so common, especially arrhythmias. All parts of the heart can be involved, so that you can have the myocardium. This is a muscle of the heart. And arrhythmia is defined that there are irregularities of the heartbeat, including when it is fast or too slow. And the pericardium, this is kind of the coat of the heart, which is a fibroelastic sac which covers the heart, all sides, except the card root, and this part can be involved too. So what we agreed on, that cardiac involvement is sign of disease activity. And if you have a new onset ventricular dysfunction, that is clearly an activity. If you have active inflammation of the myocarditis, so the muscle of the heart is kind of activity. And if you have the inflammation of the coating of the heart, that's activity too. If you have a new onset clinically important arrhythmia, that is clearly activity. And if a pulmonary hypertension occurs, what means that the pressure in the pulmonary vessels is increasing, that is clear activity. Ensure the patient-reported outcome of lung disease is clearly an activity too. The next organ was the gastrointestinal involvement. And here in every visit, they will clinically ask the complaints if the patient has problem with swallowing, heartburn, digestive problem, stool frequency, and so on. And you look at the weight and height, and in children, especially the growth. Are the children, here you see kind of a normal percentile, and here you see if the child kind of flattening during the disease. Normally, so you always want to have that the children are staying on the same percentile and developing on the same percentile. And you have the change of the body mass index. So here you have kind of the normal one, or you can overweight. And if the patient are going that way, if the normal and underweight, that is always concerning. We agreed that if the growth indices, height, weight, and body mass index are measure of disease activity, and the decrease in weight is clearly a disease activity, ensure the patient-reported outcome of gastrointestinal disease is a disease activity too. If you look at the renal involvement, you know that every patient get the blood pressure measured, and you have to be conscious that the norm values for blood pressures are children are age related. So some blood pressures, which sounds for an adult quite normal, it can be for a child quite high. So you have, again, a normal percentile curve. A very easy screening of renal involvement is the urinary test strip, where you look if there are any protein or cells are found there. And you ensure the scleroderma renal crisis that most of you heard of. It typically presents with abrupt onset of severe hypertension by rapidly progressive renal dysfunction, increased blood pressure, encephalopathy, congestive heart failure, and the microangiopathic changes. Fortunately, renal crisis is extremely rare in children. I think actually from the 280 children, what we're following, there is only one who have renal crisis. We agreed that renal involvement is a very significant sign of activity, even if it is very rare. And if an active renal crisis occur, even if it's very rare, it would be a clear sign of activity. And for Raynaud's, what you all know, here you see a child with the discolored fingers. There we asked, there's a frequency assessed by every clinical visit. You see there's a patient, the parents, because under the age of 8, we always ask the parents to assess it, where you have 0, no activity, and you have 10, very severe activity. And we ask for ulceration activity if you have open wounds on the fingertips, and that's our clearly signs of activity, and it's very easy assess for the patient, which showed in several publications that is really response during the follow-up in the inception cohort. We agreed that vascular involvement can be a sign of disease activity in the context active digital ulcers. So if you have really kind of this opening wounds on the fingertips, it's clear sign of activity. And digital ischemia is the more severe form. It's not only the tip of the fingers, but more part of the finger gets really significantly less blood. In vascular involvement, we voted for that the patient-reported outcome of vascular disease is a very good measure. Like these questions, has your Raynaud worsened? Sorry. Would you consider how much Raynaud interfered with your daily activities in the past week, or how much have finger ulcers interfered with your daily activities in the past week? Musculoskeletal movement is actually very common in children. It's around 60% of children have musculoskeletal movement, much more common in adults. And here you see the joint count, where you have all these joints, and you look which joint is swollen or limited in range or painful. And the muscle strength is assessed in several muscle groups, where you have a normal muscle strength and decreased muscle strength. And there you can collect the data on this sheet, which is here, this MMT scoring, which is a standard scoring, what is done during the visits, and you can follow it. So therefore, we voted for that joint swelling and limitation of the range is clearly activity. A tendon friction nerve is activity, but is very rare in children compared to the adults. And the inflammation of the muscle is a clear activity. And there are patient-reported outcome measures for musculoskeletal disease, which can be adopted from juvenile idiopathic arthritis, which is used very commonly, and every 500 child has juvenile arthritis. So we know that it works for this kind of involvement. I would like to make an advertisement for our inception cohort, where a lot of data which was used, how we can assess activity, was validated. So if you have a child who has systemic scleroderma and is not in the cohort, it would be nice to include him in the cohort. So you can ask your physician, and you can contact us, or your physician can contact us, and we are happy to include your child. In conclusion, what I was telling you is a proposal to assess activity. We are in the process to publish it, and we want to send this proposal for the Federal Drug Administration as for the European Medical Agency, that they should consider these activity measures if they are planning any pediatric studies. And it would be very important that we will standardize comparable assessment of the future drugs, which are evaluated in children in GSSC, and hopefully much faster and earlier, because we always have to wait till the adult studies are finishing, and then the companies start to do the pediatric studies. So perhaps you can push politically for it too, that it should be done much earlier, and we should not be, I think, 4, 5, 7 years after the adult patients get the drug, that we get to the pediatric drug use, because we cannot use the drugs if the drug is not used in any other pediatric field, because we don't have any dosing, and we don't know which kind of dose is really effective and useful. You cannot divide the adult weight, like average adult is 70 kilos, divide by 70 and multiply in the child weight and say, oh, this is the dose, because it can be sometimes too low, because mostly children have a much faster metabolic system, and they need mostly more drugs. But we have to really assess scientifically how much drug you need in which weight group to achieve the same effectiveness what you achieved in adults. So I would like to thank for your interest, that you participated in this session, and I'm looking forward to your questions.
Thank you so much for that fantastic webinar. You had mentioned the patient cohort. For folks on the meeting who may not be as familiar with a patient cohort, could you go through some of the benefits, the long-term benefits and short-term benefits of joining a cohort?
Basically, it's a rare disease, and actually from the cohort data, we were able to publish what we showed, that really you have to do a whole high-resolution CT to really assess the child at the beginning of a fibrosis. We could show, and we will submit it for the current EULAR meeting, that gastroesophageal reflux is a clear risk to develop interstitial lung disease, and therefore every child should be really assessed for it, because there is a chance to prevent that you don't have a reflux and you don't get so much ILD. So I think in the cohort, because we have so much more patient, and you have real groups when you can compare patient with interstitial lung disease and without, like you have 100 patients here and 100 patient in that groups, and then you can have really feelings. Can we develop like prognostic models, what we are working on, that can we say which kind of markers has a child who will develop a progressive disease, and this child has to be watched much more closely. And perhaps we already suggested in the previous publication, what was a consensus meeting too, that we want to have the treat to target concept for treatment, that you really tightly follow, that you can get the disease to inactivity. And all this data is not possible if you just treat 5 or 10 patients, because you don't get the data to really say, yes, this is a risk factor to have this kind of involvement, and this is a risk factor for that. Like, you can't use antibodies as a risk factor in the pediatric patients, because we could show that there's not lot of difference in patients who are SCR70 positive or negative. So it's different from adult disease. So you can't extrapolate adult risk factors to the pediatric patients. So therefore, it's very, very important to have this large pediatric cohort. And the bigger the number of the patient is, the bigger and stronger are what we can find. And how we have longer follow-up in more patients, then we can really evaluate that what we suggest, which are prognostic factor for deterioration, that they are really there or not. And the main aim is to prevent the deterioration.
Absolutely. Thank you. And a question from the audience. What arrhythmias are considered clinically important? My daughter has 11% PVCs that started in the last 2 years. Could this be considered disease activity?
Well, what does she has? 11%?
11% PVC.
What is PVC?
Pulmonary vascular. Let's see.
Pulmonary hypertension or no?
Not
Or you
pulmonary.
mean arrhythmias?
Yes, for the arrhythmias.
So I think 11% arrhythmia, I would follow it tightly, and we always work with cardiologists. And this has to be looked at as you have this kind of disciplinary treatment, but you are very concerned about arrhythmias, and in this patient, you really want to do a cardiac MRI and look if they have fibrotic islands in the heart. And it always what you have to discuss with the cardiologist. Do this patient need a pacemaker, that really you don't get problems from the arrhythmias? So that cardiologist has to decide this, how many percent, but 10% is kind of a significant number for a child.
Thank you. And for the PVCs for premature ventricular contractions, would this lead to any different response?
Yeah, I think the problem, I think the thing is that a lot of patients, we had the feeling, dying on arrhythmic complications. So that is really should be discussed from your treating cardiologist, how much the concern is. If the child had like 24-hour ECGs and so on, or Holter monitoring, and then they decide if they need any more really preventive cardiac intervention. And you would be much more active to do preventive intervention to prevent sometimes what's really deadly arrhythmias.
Thank you.
And then the cardiac MRI seems to be there is not data from pediatrics, but in adult patient, that in cardiac MRI you see some kind of fibrotic changes in the heart, which are predictive that you are more danger to develop severe arrhythmias.
Thank you. And another question, do you see a genetic association of parents having scleroderma and their children developing juvenile scleroderma?
I think, sure, if the parents have systemic scleroderma and the child has it, then in that family is a genetic association. And actually, there's a current study running in Europe. I think some US centers are participating. And it's based in Liverpool, where we look for genetic association for juvenile systemic scleroderma. So they're collecting blood and clinical data and look for genetic association. But I think clearly if both parents has it or one parent has it, then the genetic association is much clearer. But it is more common that you have more common other autoimmune diseases in the family, not directly systemic scleroderma, compared to families who don't have systemic scleroderma in their children.
And in your opinion, what is the outlook of the pediatric scleroderma clinical trial space? at the moment? I know we get a lot of questions related to how to participate and why there aren't any or very few clinical trials available for juvenile patients.
Because that's what I mentioned, that the sad news is that you get asked, I got asked from a company to work on this pediatric investigation plan for a drug which is already now in a phase 3 trials in adults. So I'm nearly finishing the trial. And then you ask, so when is the pediatric trial will happening? And they say 2032, which is totally frustrating. So I think there has to be more political pressure, perhaps over the licensing agencies, or stimulation is always better than a negative pressure, that you really ask the companies not to wait so long for the pediatric trials. Because if you have proven the efficacy in adults, you can go ahead and do the next day the pediatric trial. And we have the children because before the companies always asked for a waiver, at least in Europe, there was a possibility. They got it, the waiver, since the inception cohort is existing. And I send the European Medical Agency the data, how many patients we have. We clearly can say that for these trials where you need 30 patients perhaps for a trial, we clearly can recruit these patients. So it should not be a problem at all to recruit these patients and to really get the trials rolling.
Absolutely. And, for everyone on this meeting who watches the recording, it's a fantastic reason and to reach out to those local officials who can change these laws, who can put this stuff into effect. And, hopefully this is a proposal that is adopted by the FDA, because it sounds like it would make great change.
I think make more pressure on pharmaceutical companies. I think it's an issue of profit too.
Yeah.
You must be honest, because that's the thing. I think adult systemic scleroderma is like 1 to 3 in 100,000 adults. So it's a totally different dimension what the pediatric patients are. And presumably there are more pediatric patients if we push more. I think a lot of them perhaps are not recognized early enough. And some, I think Raynaud's is much more common in childhood, and I'm not sure that all patient who has Raynaud's is really seen by a pediatric rheumatologist and they get assessed how far there are signs for beginning systemic scleroderma. Which is, I think, a very important topic to catch these children early, because that's what I showed, that if you really look with HSCT in the lung, even early in the disease, when the children are totally happy and have no problems, they already have a beginning fibrosis. And what we could show, that actually adult studies show that we have now drugs which can really stop fibrosis. It's not so sure that it doesn't seem to me that these drugs are really reversing fibrosis. So therefore, if we stop fibrosis when it is not clinically significantly influence the quality of life of a child, then we have won against the disease. So I think therefore early recognition of early changes in the organ systems, and therefore actually if you include the child in an inception cohort, there is a real standardized protocol to look at each organ systems standardized. And it's a very good clinical practice. And a lot of physicians are telling me in centers where most centers have 1 or 2 children, so they have no idea how to follow these children. And not all children can travel to the center like Cassie Torok in Pittsburgh. She makes a fantastic work, and Cassie is doing a fantastic assessment, but not all children are at her unit. So, and a lot of children stay on the local unit, and a lot of other countries, they stay in the units where they are. And therefore, I think it's very important to have them a guidance how they should assess the patient, what the inception cohort actually basically offers.
Fantastic. And what would you say is the best way for especially for those parents who aren't able to travel, for them to share this information with their local care
Yeah,
team?
so basically, because I think even the local pediatricists can join the inception cohort, and then they get the information about the protocol, and then the patient get assessed, standardized, and then you really realize early where the organ involvement is. And that is very important because that's the first step. You have to realize what severity, activity a child has, and then you can adopt the treatment to that. And then actually you have a lot of problems with the off-label because nothing is licensed beside nintedanib for children, and even tocilizumab, which is licensed in the US to treat ILD in adults, is not licensed for children. Fortunately, tocilizumab is licensed for children to treat juvenile arthritis. So that's what I meant. So if the drug which is used in adults to treat the adults is used for a different indication in children, then it's easier to apply it because we have a dosing, we have the safety data, so we can really use it. It depends how the insurance company pays for it, but at least you have all the data how you should use it. But some drugs which are tried now in adults for systemic scleroderma are not on the pediatric market for any indication. And for that drugs, we are not able to use it. Only the children gain weight in a range where they are 50 or 60 kilos, where you would say, okay, they can use in adult dosing. So therefore, it's very, very important to push the companies that we really need the pediatric data of dosing. We don't need so much the efficacy data because you can extrapolate the efficacy data from adult studies if the drug is effective, but we really need a dosing to say, okay, what kind of drug a 10 kilo, 20 kilo, 30 kilo child needs. And we need the data that this drug is really not disturbing the development of the child. So therefore, you really should look, we really need pediatric studies where
Thank
these
you.
items are controlled.
Yeah, I think it's very important to stress that. And we've got another question from the audience. How common is are the centromere antibodies in juvenile patients?
Actually, they're very rare. So compared to adults, because we have 70% diffuse patients, which is totally much higher than adults. So adults have like 40% diffuse subset patients. And in adults, the limited subset is dominating. In pediatric, the diffuse subset. And actually, we have only 5 to 10% of the patients are anticentromere positive. So it's much, much lower. And interestingly, it stays lower even if the patient get older. I looked at the USTAR database and the Royal Free database where we looked at patients at the age of 30 who had juvenile onset, and still the juvenile onset patient stayed at this lower range with the anticentromere antibodies.
That's
But
very interesting. Yeah.
yeah, so it's not a different disease, but the subsets are different, and we have much more patients who have overlap features. So we have around 30% of patients have overlap features, mostly to myositis.
Fantastic. And we do have some comments related to parents asking if we can share some of this information via them. If it's okay with you, I'd be happy to share kind of the cohort information and other information in a follow-up email to all attendees today.
Sure.
Yeah.
I think we have made several publications from the cohort already, so that are available. And we always make a publication, and actually we asked the Scleroderma Foundation to support the cohort because it's very hard to get, because we pay for each center for every visit, which is very important that you get really data, because it's work to collect the data. We don't pay for any exams because we think that is good clinical practice, but we pay for the collection of the data, and as every 6 months the patient should be assessed and according to the protocol, and we pay for that. And we have a coordinating study nurse who is really fantastic and and coordinate this project. So therefore, we would be very happy to get more support for that, which is very hard because everybody want to have just a scientific question what they answer. But I think the whole cohort is it can answer a lot of questions if you are able to follow the patients longer and you get more data. So it would be very nice to get an independent support for the cohort that we can work further on. And the current support will run out end of this year. Yeah.
That's good to know. So again, if anyone knows or is well connected, please feel free to get in contact with Dr. Foeldvari or the cohort. I can't stress enough how important it is to get your child, signed up for the cohort so they can track this data and hopefully make some grand changes in the future. And we have one more question. And if anyone else has any questions, please feel free to drop them in the chat or the Q&A function. The attendee asks, what are the earliest symptoms of juvenile systemic scleroderma generally?
I think generally most common is Raynaud. That's what the most common is. And some other children got missed that they have arthritis because they get these puffy fingers and they get these contractures of the fingers. And that is the most common beginning symptom, that they have really Raynaud's and then say, oh yeah, you can have Raynaud's. Especially I think in male patients, if you have Raynaud's, and especially I think if the Raynaud occur before puberty, you should be very concerned because that is very uncommon. The primary Raynaud, which around 5% of the adult population has, and it starts in adolescence, that starts more there. And then are some things what you can do very easily. You can look at the antibody profile and you can look if they have already antibodies. Some of them already have just Raynaud's and antibodies at the beginning, and they have nail fold capillary changes. So we published, I think, years ago that we suggest in every child who has Raynaud's that at least they should have at the beginning an antibody profile for ANA, and they should have a nail fold capilloscopy. And there are norm values now for nail fold capilloscopy. We had a ULAR microcirculation project for children to develop and norm values for nail fold capilloscopy. And this is very important because children have a different number of capillaries, how they are growing, and some changes which are pathologic in adults, it can be normal in a child. So you have to know what the norm values are. But now this is published and we are working on it progressively. But we could show that in the cohort, children with nail fold capillary changes have more pulmonary movement, more cardiac movement than children who don't have any nail fold capillary changes. So I think all this data, like that is from the cohort again, where we showed, but at the beginning, you would really look at the nail fold capillary changes. If you have a Raynaud, you really want to assess the joints. If you have any sign of sclerodactyly, that the fingers get and then contractures, if you have a tight or puffy skin, and even at that time, the children can have even fibrosis of the lung already. So therefore, if you look at this, the assessment, what we suggest in the inception cohort, that is very helpful to do this kind of staging when a child, especially if they have Raynaud's and antibodies, that you really look, is there anything else which is coming up and shows the direction that this child will develop something else, like what was asked, if they would have anti-centromere antibodies or anti-SLC antibodies or anti-PMSCL antibodies which are more specific. It doesn't mean that the child has to develop systemic scleroderma, but you should tightly watch these children, how they develop and what they develop, to prevent any complications.
That's even more important why these assessments are so vital. Thank you so much for joining us today.
Yeah, welcome.
Fantastic.
I'm very happy to join again. So it's
oh, absolutely. We're always happy to have you, Dr. Foeldvari. And do you have any parting comments for the audience?
Yeah, I think they're all, so if they have questions, they can write me an email, and you can give them my email address. I'm very happy to answer them. And if they would like to be part of the cohort, or they have question of the cohort, they are happy to contact me directly. And if somebody has some financial support what they see for the cohorts, it would be great that we can carry on with this work.
Fantastic. Thank you. Yeah, I will share that contact information and recording and other follow-up information in an email I'll send out end of day today. Thank you again for everyone for joining us today. Thank you, Dr. Foeldvari, and I hope that everyone has a wonderful afternoon and evening.
Yes, absolutely. Thanks for joining.
Bye.